Welcome to Connected by Health. I'm Dr. Krishna Vedala. This is where medicine meets leadership, innovation, and humanity with one goal: to add value and help change healthcare for the better. If you believe health is about more than a diagnosis, you're in the right place. Primary care is often called the front door of the healthcare system. It's where prevention happens, where chronic disease is managed, and where trust between patients and clinicians is built over time. And yet, in the United States, that front door is cracking. Welcome once again to our podcast. And today's episode is a deep dive, an exploration of primary care reform, why primary care matters, why it's failing under the current structures, and what reforms are being tried, and critically, what stands in the way of real lasting change. This is not a theoretical conversation. It's about access, cost, burnout, equity, and the sustainability of care for generations to come. So let's begin. But first off, let's talk about this: why primary care matters. You see, primary care does more than just treat illness, it prevents it. Decades of research show that health systems built on strong primary care have the following: they have lower mortality rates, they have fewer hospitalizations, they have better chronic disease control, and of course, lower overall healthcare costs. And that's important. Yet, despite its value, primary care remains chronically underfunded. Because here, my friends, is the reality. Primary care accounts for about 4 to 5% of total U.S. healthcare spending. About 4 to 5%. The U.S. spends nearly $4.5 trillion annually on healthcare, and yet a very small percentage, 4 to 5%, goes towards prevention, continuity, and coordination. Now, let's compare that with other high-income countries, many of which have invested double or triple that percentage in primary care, and they've achieved better population health outcomes. Primary care is where hypertension is controlled before it becomes stroke, where diabetes is managed before it becomes kidney failure, where mental health needs are identified early, where the social determinants of health are first recognized. And you see, when primary care works, everything downstream works better. So why does the system treat it like an afterthought, though? Another aspect that we really have to consider is the primary care workforce crisis. Obviously, any discussion of reform has to start with the people. The United States is facing a severe and a worsening primary care workforce shortage. Of course, let's talk about some key data points. Over 7,900 or 7,900 federally designated primary care shortage areas. More than 30% of U.S. adults, more than 30% of U.S. adults lack a usual source of care. Primary care physicians, sadly, earn about 100,000, 200,000 less annually than many specialists. Medical students now graduate with an average of education depth exceeding greater than 200,000. And the result? What else can we expect? Fewer students often choose family medicine or general internal medicine. And of course, even if they do, early career clinicians burn out faster. Rural and underserved communities struggle. They struggle to recruit and retain providers. And I know this because I did my residency for internal medicine at White River Health System in Batesville, Arkansas, and I know how difficult it is to recruit providers to rural areas. Now, primary care clinicians are expected to do a lot of things. We're expected to manage increasingly complex patients, address somehow mental health and social needs with very little resources, and of course, coordinate care across fragmented systems and complete extensive documentation. And I can once again be a firsthand perspective for that because I know how much time I spend on documentation on a daily basis and on a weekly basis. But doing all this while being paid less per visit than most physicians that conduct or perform in procedural specialties. And so it's this mismatch between responsibility and reward that is not accidental. This just didn't happen by accident. You see, this is structural. And we have to change that if we want to reform primary care. Now let's talk about something also important, which is access, equity, and the patient experience. From the patient side, the consequences are very, very tangible. Many Americans experience weeks and sometimes months-long waits for appointments. Brief visits that feel rushed, difficulty finding a clinician who accepts their insurance. I'm pretty sure everyone here who's listening has had to face that. And of course, in the rural areas, sadly, long travel distances. And these access problems are not evenly distributed. Communities most affected by such issues include rural populations and, sadly, low-income urban neighborhoods, and of course, communities of color, and patients with Medicaid or dual eligibility. Primary care gaps directly worsen healthcare disparities. This is proven. There's been many studies that we could spend days talking about, confirming that primary care gaps directly worsen health disparities. In areas with higher primary care gaps, you will tend to see higher emergency department use, which of course leads to greater healthcare costs. You'll also see later diagnoses, which unfortunately means it's too late at times to save the patient's lives. And of course, you'll also see worse chronic disease outcomes, which we are facing right now, and higher long-term costs. Again, when you have a system that invests in primary care, you will see lower costs. But when you have a system that ignores primary care, you will continue to see higher long-term costs. You see, when primary care access disappears, what do patients do? Well, they'll do the only other choice that they have and the only place that they can go to, emergency rooms. And emergency rooms become the default care. And this is the most expensive and the least preventative setting possible. And that's a problem. That is a big problem. So how do we go about looking at fixing this issue about reforming primary care? Well, it has to start first with payment reform, and we also need to look at newer primary care models. So you see, at the heart of primary care reform is one core issue: how we pay for care. This all comes down to how we pay for it. The traditional fee-for-service model rewards volume, not value. It also rewards short visits over longitudinal care. It also rewards procedures over prevention. And any attempt at primary care reform must put emphasis on aiming to reverse that, aiming to reverse this value of valuing volume over value, about valuing prevention over procedures. Key reform approaches: there's some new models that we have been looking at and also practicing over the past decade. First off, we need to look into value-based payment models. This is essentially per member, per month payments. It also incorporates quality bonuses. In other words, physicians and other providers get paid more based on certain quality metrics that are selected. It is also based on reduced reliance on visit billing. Value-based care is a very, very interesting concept that we could do a whole episode on, and we will in this podcast, by the way. But in addition to value-based care, we also can look at advanced primary care models. So certain CMS programs like Primary Care First and Making Care Primary. So this model emphasizes care coordination and population health. It looks into financial stability for practices. Another based model that we can look at is team-based care. This is incorporating nurse practitioners and physician assistants into working with primary care physicians. They also look at incorporating behavioral health integration, which is a huge must and a huge need nowadays. And they also look at incorporating community health workers. Another model that is really rising quickly because of the advent of technology is technology enabled care. Technology enabled care incorporates telehealth visits and remote monitoring, which is still an evolving field, and of course, data driven population management. But regardless of what type of model, all of these models show promise. However, here's the problem: adoption remains very limited. Why is that? Well, that brings us to the biggest question of all. What are some barriers to primary care reform? If primary care reform makes any sense clinically, financially, and ethically, why hasn't it happened already? Why hasn't it happened at such a large scale? Well, there are several powerful barriers, and let's talk about them. Number one, payment inertia. What does payment inertia mean? Well, healthcare financing is deeply entrenched. You see, the fee for service really benefits hospitals and specialists, and primary care reform shifts that revenue away from these high margin services. Now, the issue is over the last couple of decades in the United States, through a series of mergers, acquisitions, which some will say was a necessary need to meet the demands of an ever-changing healthcare system. But we now have these consortiums of different large healthcare systems, and when you have those, they resist changes that may threaten the existing profit structures. It's difficult when you have these bigger health systems and they are resistant because they're worried about what the profit margins will be if a new system that is instituted that helps emphasize the importance of primary care. Another issue to really look at, another barrier, is fragmented payer landscape. See, primary care practices deal with a variety of different payers or insurances. Number one, Medicare, and of course, Medicaid. Multiple commercial insurers such as Blue Cross Blue Shield, Aetna, and several others. However, each of these payers have a different set of rules, a different set of metrics, different set of incentives. And it's a complex web of different payers with coming up with different ways to pay providers and hospital systems. And it's gotten to the point where a practice may actually operate under 5 payment models at once. And this is a problem. It's a problem because any kind of reform, any kind of transformation becomes automatically expensive and it becomes very confusing. Another barrier to really look into, in addition to the ones we just talked about, are upfront costs and risks. You see, transitioning into a value based care requires a lot of effort, but a lot of different investments in a lot of different parameters. First and foremost, data infrastructure. Data has become key to running hospital systems. It's become key to making decisions. And so you really have to invest in data infrastructure, and that is expensive, as we all know. Care coordinators. I have to admit, one of my favorite roles as a primary care physician, and one of the roles I really, really lean on, is my clinical care coordination team. And these are trained individuals that really make sure that patient care is not being missing or ignored, especially when they're going in from the outpatient, meaning in the clinic side, to the hospital side, in the inpatient, and of course, vice versa, is how important of a role care coordinators are. But another upfront cost and risk to look at are new workflows, and that's a whole different topic by itself. So, one of the other things that we've seen over the last couple of decades is this decrease in independent and small practices. And part of the problem with that is just the overhead cost, but also the cost to continuously update, upgrade, invest in yourself. It's difficult because a lot of these small and independent practices often lack the capital to invest, even if the long term benefits are clear. Another barrier to look at, and this cannot be understated, which is workforce burnout and capacity. Reform requires energy, but here's the problem. Many of those of us in healthcare, whether if we're clinicians or ancillary staff or even administrators, we're all already exhausted. Burnout rates, unfortunately, among primary care physicians exceeds greater than 50%. And that's a problem because that really does limit the ability of primary care physicians to redesign care. And if you're already burnt out, why would you want to take on more risk? And of course, why would you want to spend the time and investment in participating in pilot study? You already have enough problems on your hand, right? Another barrier, I cannot disagree with this whatsoever because I know how difficult this is on a day to day basis, but regulatory complexity. Well intended regulations can create a lot of problems. Number one, again, documentation overload. Number two, reporting fatigue. Number three, administrative burden. Because you see, clinicians today, thanks to regulations and regulatory burdens, often end up spending more time on paperwork than actually on patient care. And of course, the biggest barrier, and this cannot be ignored, which is political and policy instability. If we want to reform primary care, there needs to be long-term commitment. But the problem is payment models keep changing with administrators and with different administrations. Pilot programs often expire once without really any notice whatsoever. And of course, funding is uncertain. Transformation or change just can't happen in 2-year cycles. That's just not doable. Healthcare is about saving lives, and it should never really be about playing politics. That's really not what healthcare is about. There's not really two sides to saving lives, my friends. It's pretty clear and it's pretty cut. It's either you want to save lives using evidence based and accurate medicine and data that is reliable, or you don't. That's really what it comes down to. So, what would, if we were to reform it, what would successful reform look like? Well, you see, when we see primary care reform working, here's what we'll see: stable, predictable revenue for practices, longer visits when needed, proactive outreach to high risk patients, and of course, better integration of behavioral health and reduced emergency and hospital utilization, because that's really where the greater cost is coming from. It has been shown and it's been proven the states that set primary care spending targets are now beginning to show progress. Not necessarily overnight, and I'll admit that. This is not going to be, oh, we're going to reform primary care for the better and we're going to fix the healthcare system. And that's not what I'm advocating, or it's not what I'm stating. It'll happen, but it'll take time. But despite the time and the effort, this lesson is clear. Where primary care reform has been done for the benefit, we have noticed that it's about realigning priorities. It's no longer just about program or payment models. And that's important. So let's talk now about what can we do? How can we reform and come up with some specific policies that could be instituted to reform primary care? If reforming primary care is going to move beyond just sample pilot programs and white papers, it has to be driven not by just good intentions, but actual policy choices. So let's get specific. And this is what meaningful primary care reform will actually require from policymakers and administrators. Number one, if we want to reform primary care, we need to set and enforce primary care spending targets. At the state and the federal level, policymakers need to establish minimum primary care spending benchmarks. For example, something along the lines of 10 to 12% of total health spending directed towards primary care over time. I think that is a doable, achievable benchmark. We also need to require transparent reporting from insurers and health systems on how primary care dollars are defined and how they're spent. And we also need to tie compliance not to voluntary participation, not just, oh, here you go, here's a reward for just participating, but actually tie compliance to accountability. States that have adopted such measures, that have adopted spending targets, have already shown that measurement alone doesn't change behavior. You can't just fix it when you don't track. And right now, as we know, primary care is invisible in most budgets. So the key is if primary care is foundational, it must be funded like the bricks, like infrastructure. It should not be treated like an optional add-on. Second, we really need to look at reforming Medicare payment to stabilize primary care revenue. This is one of the reasons why independent primary care practice has been dying out over the last couple of decades here in the United States. Because you see, Medicare really sets the tone for the entire system. A lot of other commercial payers really look to Medicare for making any decisions, for making any changes. And so policymakers really should look at expanding prospective per member, per monthly payments for primary care. They need to reduce this whole over-reliance that we have right now on visit-based billing. Oh, how many visits has this physician had in the last week or in the last month? We need to get away from that. We also need to have Medicare look at increasing payment for care coordination, for longitudinal relationships, and also for patient complexity. We also need to look at really making advanced primary care models default pathways, not just competitive pilot studies. Short-term demonstration projects are not enough. Primary care practices need predictable long-term revenue to do a lot, to hire staff, to continuously invest in themselves, to continuously invest in upgrading technology to meet the demands of an ever-changing world. They need financial revenue to redesign care. And you cannot ask clinicians alone to transform care while forcing them to survive on instability and on unstable and unreliable payment models. Number three, we need to reduce administrative and reporting burden. Policymakers often say that they want physicians to spend more time with patients and then require dozens of overlapping quality measures. And once again, I can vouch for that. You see, reform, my friends, should include alignment of quality metrics across different payers, not just for individual payers, because you can't have 6 or 7 different payers, each requiring different things. They all have to require the same thing in order to create uniformity. We also need to look at eliminating low-value documentation requirements. And it probably wouldn't hurt to have fewer measures, but ones that actually reflect outcomes patients care about. We also need to really look at investing in automatic data sharing instead of just manual reporting every month or every quarter. Because every hour spent on redundant reporting is an hour not spent on care. Administrative burden is not just a nuisance, my friends. It is a direct threat to workforce retention and to causing more burnout. We also need to look at investing directly into the primary care workforce. And workforce reform isn't just about rhetoric. It really has to include policies that include loan forgiveness and debt relief tied to primary care service. We have tried this, and we are still trying it. But clearly, it's just not working with what we have. So we need to really look at true loan forgiveness and true relief tied to primary care service. We also need to look at increasing funding for residency slots in family medicine, general internal medicine, and pediatrics, and also OBGYN. We need to look at support for team-based care, including nurses. We also need to look at support for behavioral health clinicians and community health workers. They're all part of a team, and they all help take care of patients, and we need to do our best to support them. Immigration and licensure policies that actually responsibly expand the workforce. Now, of course, we could talk about this for a whole day, but we actually do need to look at creating a immigration policy that emphasizes metrics that are measurable, but also that emphasizes a incentive to going into primary care. If policymakers want more physicians to choose primary care, the math has to work. It's that simple. You cannot solve a workforce crisis without changing the realities of the financial and the professional commitments of that job. In addition, we also need to look at And this is something I've become really big on because of the tremendous decrease that we have seen in independent and small based practices. But we need to protect those practices because primary care reform cannot just accelerate consolidation, and that's never good. What we need to look at are policies that provide upfront transformation funding for small and independent practices. And we can do that by ensuring value based models that are accessible without having a requirement for healthcare or health system ownership. We need to prevent payment models that reward scale over quality, and we need to support safety net and rural practices because as and when independent practices have begun to disappear, access often has followed. And so primary care reform that only works for these larger systems is not reform. That is not reform. That's mostly just consolidation. And that's not what we need. We also need to look at commitment to long term policy stability. And this is important. Healthcare needs to have a stable environment in order to continue to grow, but also in order to continue to grow for the betterment of the people. And this aspect of instability can be very damaging. And so, what we need to look at from a policy side is commitment to multi year payment models. It just can't be an annual anymore, an annually payment model or a biannual payment model. We have to look at multi year payment models. We need to avoid frequent redesigns that often force practices to constantly adapt. We need to provide clear roadmaps for reform that extend beyond just one election cycle. We can't keep doing that because primary care transformation and reform takes time. It's not going to be done just overnight. And remember, trust, trust takes even longer. And that's the problem. You can't rebuild the foundation of healthcare on these simple, short term policy cycles. And so, primary care reform is not a mystery. The evidence is there, the models exist, the need is undeniable. And what's really missing is this policy alignment with the values we talked about. Because if prevention really matters, well, maybe it's a good thing to fund it, to give it money. If access matters, well, maybe we should protect it. Maybe we should protect the small systems, the independent practices. And if clinicians matter, maybe we need to stop burning them all out with systems designed to fail. Primary care is the front door of healthcare. And policy decides whether that door is going to be kept open, reinforced, or just boarded shut. Primary care reform is not optional because without it, costs will continue to rise, burnout will continue to worsen, access will continue to shrink, and healthcare disparities will widen. And then what about if primary care reform actually is done? Well, I'll tell you what can happen. Patient care, becomes more humane. Communities become more healthier. The system becomes more sustainable. If healthcare is a system, primary care is its foundation. And systems don't stand long when their foundations are ignored. If this episode resonated with you, share it with someone shaping policy, running a healthcare system, or delivering care on the front lines. Thank you. If you found this conversation valuable, share it with someone who could use it. And if you're on Apple, we'd love to hear your favorite takeaway in a review. See you next week.